welcome to my coronavirus classroom. I'm Janessa Jacobs, and these are the joints. So, as with everything in anatomy and physiology, we classify our joints based on their structure and then based on their function. So, first, what do we find between the bones in the joint? And second, how much movement does the joint allow? So, our first way of classifying joints by structural classification is what we call fibrous joints. And in our fibrous joints, we have fibrous connective tissue between our bones. Okay, so what are some examples of this? We've got 3 examples of this. The sutures that you find in your skull, we already talked about last class. We said that these sutures were these joints that you find between the bones and the skull. Those are fibrous joints, okay? So, all right, sutures, the first type. The second type of fibrous joint we have is what's called a syndesmosis, or syndesmoses. And here, this can be where we have like a little ligament attaching 2 bones to each other, or my favorite examples are what are called interosseous membranes between your radius and ulna and your tibia and fibula. So if you look in your book, you should be able to see them somewhere. There are these bands of fibrous connective tissue, and what's cool about the interosseous membranes is you've got 2 layers, one that's going this way, one where the collagen fibers are going this way, and what it does is create this nice joint that allows for some movement between those bones. So syndesmoses are another example. And then the last type of fibrous joint is one called the gomphosis, and we really only find these in the mandible and the maxilla. What's unique about the mandible and the maxilla? They contain teeth, right? And so you've got this little periodontal ligament that helps to attach your tooth into that socket. So that joint between that periodontal ligament and your tooth is a gomphosis. So those are our 3 types of fibrous joints. And again, they've got some fibrous connective tissue between the bones and the joint. Next, we have cartilaginous joints. And in cartilaginous joints, you have cartilage between the bones and the joint. And the type of cartilage you have is going to determine the type of cartilaginous joint you have. So the first ones are called synchondroses. And in synchondroses, we have hyaline cartilage between the bones. So a good example of this would be between true rib 1 and the manubrium of your sternum. That is a synchondrosis. All of the rest of these joints are synovial joints. So the only one where we're connecting the bone, true rib 1, to the bone by hyaline cartilage only is this one right here. So that's a synchondrosis. And you'll say, yeah, but the rest of these have bone attached to costal cartilage attached to the sternum. Sure, but these are synovial joints, which means they have joint cavities. And if you think about it, we can really move to increase or depress if we need to. You wouldn't be able to move if all you had there between the rest of those was hyaline cartilage. Okay, so synchondroses, we find a joint between the bones. Another example of a synchondrosis is you actually have a temporary synchondrosis in all of your developing long bones. So if you think about it, in your developing long bones, when they're growing, the diaphysis is bone and the epiphyses are bone, and the epiphyseal plate is hyaline cartilage. So the epiphyseal plate is a temporary synchondrosis. Okay? So just be aware of that. Now, if we have fibrocartilage between the bones and the joint, that is a second type of cartilaginous joint called the symphysis. And so in a symphysis, we have fibrocartilage between the bones. So all of our intervertebral discs are symphyses, and the pubic symphysis is a symphysis. So all of the intervertebral discs here are symphyses, and the pubic symphysis down there between your pubic bones is also a symphysis. And you might say, well, what about the meniscus of the knee? Is that a symphysis? The answer is no. The knee is the most complex synovial joint in your body, and that's what we'll talk about next. So, where's my clicker? Okay, so synovial joints contain a joint capsule, and it's full of some synovial fluid that helps to smooth out and lubricate that joint, so you've got nice smooth movement between joints. So, synovial joints. For now, we'll say these contain a joint capsule that's full of some kind of synovial fluid. How it's arranged will differ depending on the joint, but this is the only one that contains a joint capsule. And that joint capsule has synovial fluid in it. We'll talk more about that in a little bit. So usually what I do in a normal class is I have a board over there and a board over there. So what I do is write all of these things down on the board over here so that when we next talk about our other way of classifying it, we can lay all of the two together. So I don't know how to do that easily right here. We'll do it maybe the opposite way. Okay, so the other way that we can classify our joints is based on how much movement they allow or their functional classification. So, synarthritic joints allow no movement. So these allow no movement. Say, well, what good of a joint is that if it allows no movement? Well, if you're holding two skull bones together, that's a great job and a great joint. So, no movement is allowed between the bones and the synarthritic joint. Okay? Antiarthritic joints allow some movement. Okay? And synovial joints, diarthritic joints, diarthroses are freely movable. And the reason I said synovial is because synovial joints are the only joints that are freely movable, and they're diarthritic. So that's kind of weird because some of your synovial joints that are freely movable have very limited range of motion. So synovial joints have joint capsules, and because of that, we consider them freely movable. So let's think about then how do our different structural types lay on to this functional classification. So for fibrous joints, sutures. How much movement do sutures allow? They allow no movement, right? They're synarthritic. So for synarthrosis, some examples, a specific example, a fibrous joint by structural classification, and our suture by its specific name is a synarthritic joint. Now, what about our syndesmoses, the next kind of fibrous joint? Do they allow no movement? Some movement is freely movable, like those interosseous membranes between your radius and ulna. They allow some movement. So your syndesmoses were fibrous joints that by structural classification, they're amphiarthritic by functional classification, and their name is syndesmosis or syndesmoses. Okay? And then the last type of fibrous joint we had was the gomphosis, the periodontal ligament in your tooth. How much movement do you think that's supposed to allow? None, right? So a gomphosis is a fibrous joint that is a synarthrosis. So our gomphoses are synarthritic joints. Okay. Now, cartilaginous joints. We had our bones that are connected by hyaline cartilage are synchondroses. So, synchondroses, true rib 1, manubrium of your sternum. And then also that temporary synchondrosis of your epiphyseal plate. How much movement? None, some, freely movable. You're right, none. So, for another type of synarthrosis, we have cartilaginous, specifically our synchondrosis, or synchondroses. Okay, the other type of cartilaginous joint we had fibrocartilage between the bones. It was a symphysis. How much movement do you think they allow? No movement, some movement, lots of movement. They allow some movement. So each individual intervertebral disc is not going to give you a whole lot of movement. The entire vertebral column has pretty good range of motion, but these are kind of semi-movable. movable. They're semi-movable. They're semi-movable. They allow for some movement. They are cartilaginous. And they are symphyses. Okay, the only freely movable joints are synovial joints. All synovial joints are considered freely movable, even though all of your synovial joints have varying ranges of motion. So, one of the most fluid or movable joints in your body is the glenohumeral joint. Okay? So there's a lot of movement right there. Very obviously freely movable. This joint right here, between your sacrum and your ilium, is called the SI joint, the sacroiliac joint. That is freely movable. Do you know how much it freely moves? Not a lot. So your synovial joints still have varying ranges of motion, even though they're considered freely movable. You just gotta memorize it and deal with it. Why? I don't make the rules, I just follow them, and you do too. Okay. Quick question for you. Joints can be classified structurally as A, fibrous, B, cartilaginous, C, synovial, D, all of the above. Yeah, you're right, all of the above. Great job. Okay. Fibrous joints. Aha! We talked about these already. Look at that. Sutures connect the joints. These are the joints we find in the bones of the skull. Syndesmoses are interosseous membranes, ligaments between bones. Gomphoses, periodontal ligament holding your tooth into its socket. Cartilaginous joints, synchondroses, where we have hyaline cartilage between the bones. The joint between true rib 1 and the manubrium of the sternum is one. The epiphyseal plate is a temporary synchondrosis. Symphysis has fibrocartilage in between it. We find them in the intervertebral discs and in the pubic symphysis. All right, here we go. Which joint is the site of interstitial growth in long bones? A, syndesmosis, B, synchondrosis, C, synarthrosis, D, all of the above. Yeah, the answer is synchondrosis. And you might say, yeah, but it's a synarthrosis. Well, sure, but we have more than one type of synarthrosis. Synarthrosis just means you don't allow any movement. And we don't allow any movement there, but the site of interstitial growth is the epiphyseal plate, which is a synchondrosis. Okay. When someone has slipped a disc, they have disrupted what type of joint? A, symphysis, B, cartilaginous, C, synovial, D, all of the above, E, A and B only. Yeah, you're right, this time it is A and B only because the symphysis is a cartilaginous joint. Your intervertebral discs are those, so that's the answer. All right, synovial joints. So there are a ton of synovial joints and you can look them over in your book. There's a big chart that has every bone in your body and every joint, and it shows you the structural functional classification and what it is by each. I'm going to need you to memorize all of those for everything, for every bone. Just joking. So, all right, general features of synovial joints. One, they all contain articular cartilage. What's articular cartilage? What type? Hyaline cartilage, right? And it's the hyaline cartilage that we find covering the ends of long bones and joints, right? Right. So articular cartilage, hyaline cartilage, covering the ends of the bone. So I think in your picture it shows, or in your book you've got a figure of a general schematic of a synovial joint. So let's just say here's one bone, and here's the other bone in black. Each of our synovial joints is going to have those bones are going to be covered in some articular cartilage. Okay, the next thing is that we're going to have a joint cavity, and this joint cavity is going to contain synovial fluid. Synovial fluid is like thicker than water. It's like this gel-like substance that helps to reduce friction between the bones and the joint. So we could say this is a space containing synovial fluid. And there are a couple things that are going to hold this joint cavity together. So we'll just kind of draw it up here as we go. So the end of my long bone is covered in my articular cartilage. I've got a joint cavity there. And in that joint cavity I've got synovial fluid. And it also has an articular capsule. So what we see then, to make this joint cavity, we've got this capsule that holds it all together. And in your articular capsule, the inner layer is the synovial fluid, and the outer layer is a fibrous layer that's helping to kind of contain and give it structure. Then we have synovial fluid. We could say this is a viscous fluid that reduces friction between the bones. Then we'll find reinforcing ligaments. So this is why I don't like ligaments as the only example, or as the example of a syndesmosis, is because not all of your ligaments are syndesmoses. Sometimes you've got reinforcing ligaments that are part of synovial joints. And so in this case, it would be a ligament, which is dense, regular connective tissue that's connecting the bone to the bone and reinforcing the joint. So we'll just say these are ligaments that support the joint. And ligaments attach bone to bone, right? So we should have learned that a long time ago. And the last thing is that joints are living. We've got cells in here secreting synovial fluid. We've got nociceptors in here that are going to be able to detect pain. We've got proprioceptors in here that are detecting limb position. So we've got lots of stuff in here doing stuff, which means that we need nerve and blood supply and lymphatics as well. So just be aware of that. The joint is this complex structure that has to have all that stuff. Those are the general features of all of our synovial joints, okay? So one of the things about our different synovial joints then is this synovial fluid can be found packaged in different ways in different joints. So let me erase this board and we'll come back to that. Okay, so in joints you can have little membrane-bound sacs of synovial fluid. If it's like a sac, it's a bursa. So membrane-bound sacs of synovial fluid. Okay. You can also find tendon sheaths. And so a great place that you see tendon sheaths is in your hand. So if you look, the muscles that control these movements of my fingers are up here in my arm. Whoa, did that just blow your mind? Should have. So, all of these fingers are moving because of muscles here, which means that these tendons, which attach muscles to bone, are going over all of these bones in here. So my carpals and my metacarpals. So what I can do for these tendons so that they don't rub against those bones, and then for the bones underneath for that matter, so the tendons aren't rubbing all over them, is I can connect, or I can contain it in this thing called a tendon sheath. That's like it's a sheath. It's like this tissue-like big long band that covers tendons and contains synovial fluid so that we don't feel all of those tendons rubbing on those bones as we move. So tendon sheaths. These are like long sacs or long packages of synovial fluid that protect tendons. It's like 90 degrees in my house right now, and I want to be done with the lecture like you would not believe. So we're going to race through this, and you're going to slow it down to 50% if you have to. Planes of movement. Synovial joints can allow movement in one plane, and that would be uniaxial. Or I can allow movement in two planes, and that would be biaxial. Or I can allow movement in mounted planes, and then that would be multi-axial. And that's all we're going to say about that. Movements allowed. So, synovial joints, what movements are allowed? Gliding joints are little movements where, like in your carpals, where we're just sliding two bones past each other. So, if I am moving my hand, then I can glide my carpals and my metacarpals past each other. Okay? Okay, gliding movements. Angular movements. Angular movements change the angle between our bones and the joint. So angular. We're changing the angle. And the reason I wrote it up over here is because I'm going to define all of our angular movements. Flexion is going to decrease the angle between our bones. So flexion decreases the angle between the bones. So for flexion of my forearm, biceps brachii is the agonist, and a synergist would be like brachialis, and an antagonist would be triceps, okay? But if I'm decreasing the angle, I am flexing, okay? If I am increasing the angle, I am extending. So extension increases the angle, but only to anatomical position. So, or 180 degrees. Why do I make a big deal about saying that? Because I could go beyond 180 degrees in some joints and hyperextend. I can't do it here in my arm, but if my hand is flexed, I could extend it, and then I could hyperextend it, right? So hyperextension, I can also do it in my head. I could flex, I could extend, and I could hyperextend. So hyperextension moves or increases the angle beyond anatomical position and beyond 180 degrees. So this increases our angle beyond 180 degrees, and it's going to move us out of anatomical position. Flexion also moves you out of anatomical position, to be fair. And then extension brings you back, and hyperextension moves you out again. Okay, abduction. This is an angular motion where now I'm in the coronal plane and I'm moving something away from the midline. So I can abduct my arm, I can abduct my hand, I can abduct my finger. Abduction moves away from the midline. Adduction brings you back, you add it back. So if I come toward the midline, then I can adduct my arm, I can adduct my hand, I can adduct my finger. So this moves you toward the midline. And then last we have circumduction. So I'll write that over here. In circumduction, this is a complex range of motion where multiple muscles around the joint are going to move the joint in 360 degrees. So I can circumduct my head, I could circumduct my arm, I can circumduct my hand, and so two things are going on. I'm moving in 360 degrees, and the distal part, it has a lot more range of motion than the proximal part. So for circumduction, we'll say this is a complex series of movements leading to a circle in 360 degrees, and we have more movement at the distal end of the joint than at the proximal end of the limb or whatever, you know. Because the joint that's moving right here is my glenohumeral joint. What is moving is my arm and my forearm, and my, out here I have a lot, like that's a lot, that's a big 360 degrees. Right here it's just a very small 360 degrees. Okay? All right. Next we have rotational movements, and in rotational movements we are not changing the angle, we're just rotating on the axis. So I can do medial rotation where I rotate toward the midline. So right now I could medially rotate, or I can do lateral rotation where I rotate away from the midline. So in our rotational movements, we're not changing the angle. So we don't change the angle, we rotate on an axis. And if we rotate away from them, or if we rotate toward the midline, this would be medial rotation. And if we rotate away from the midline, then it's lateral rotation. So when I'm shaking my head no, that is not a good anatomical and physiological answer. If I were to ask ask you what movement is allowed between C1 and C2, and you were to tell me shaking my head no, I would say, medial and laterally rotate, that is not the answer. Lateral, medial, lateral, medial, lateral, medial. Lateral and medial rotation of my head happens at the joint between C1 and C2. We went over that with bones today. Okay? Flexion and extension of my head is happening because of the joint between C1 and the occipital bone. Put that in your back pocket and nod with it. Okay, special movements. Okay, these are going to occur only at some joints, not all joints. Supination and pronation occur only in the hand. Or you can think about what are happening to the bones, what is happening to the bones in the forearm. When I'm in anatomical position, I'm supinated. I can hold a cup of soup. My palms are facing anterior, my radius and my ulna are parallel. If I flip my radii over my ulna, then I'm pronated. So now my radius is going to cross over my ulna, and I'm pronating. So in supination, this is when my radius and ulna are parallel. And we'll just put in our pocket that this is when I'm in anatomical position. This is how my hand is. So anatomical position of the hand is supination. And you can hold a cup of soup. Not if you're in anatomical position, but if you flex your forearm, then you can hold a cup of soup with a supinated hand. In a pronated hand, you flip your radius over the ulna, so radius crosses ulna. Now I'm pronated. I can always tell where my radius is by where my thumb is. Radius goes with the thumb. Okay, dorsiflexion is a special movement of the foot, and it's when we pull the dorsal surface of the foot superiorly. So dorsiflexion, okay, is when, you can say, why isn't this just flexion? I don't know, I don't make the rules, because this is plantar flexion, when you point your toes, okay? So those are special movements of our feet. What the heck just happened? Special movements of the feet, dorsiflexion and plantar flexion. So dorsiflexion is when you pull your toes superiorly toward the dorsum of your foot. Pull toes superiorly, like towards your head, right? Or toward the dorsal surface of your foot. Plantar flexion is what ballerinas are doing all day long. So they have super hypermobile, like femurs. That joint, their femurs into their ascox will blow my mind. But they're also good plantar flexors. So when you're plantar flexing, you're pointing your toes toward the plantar surface or tippy-toeing. So point toes to the plantar surface. Okay, and we met muscles of the day who do these things, so I hope you people remembered that and studied as we went. I would ask you the questions and give you the answers, but I'm getting hotter and sweatier and grumpier with every moment that goes by. Inversion is when you take the plantar surface of your foot and move it toward the midline. Eversion is when you take the plantar surface of your foot and move it laterally. So inversion and eversion are special movements of the foot, and in inversion the plantar surface comes medially. And did I just say that wrong? In inversion, the plantar surface comes medially. In eversion, the plantar surface goes laterally. Even if I said it wrong, I'm not editing because I'm hot and grumpy. Maybe I'm the lab assistant again. You never can tell. Other special movements. Protraction and retraction are opposites. Protraction and protraction, I'm moving something interiorly. So I can protract my mandible, I can protract my scapula, okay? The opposite is retraction. Moving posteriorly. I can protract my mandible. Wait, protract, I can retract my mandible, protract my shoulder, retract my shoulders, okay? So protraction moves anterior. Retraction, move, posterior. Okay, well, what if I move superior? Then I'm elevating. What if I depression. So I can also elevate and depress my mandible. I can elevate and depress my shoulder. I can elevate and depress my hip to some extent. So yeah, elevation, movement in the superior direction. So chewing is just a whole bunch of jaw elevation and depression. So depression, move in the inferior direction, or move inferiorly. And then the last special movement that we have is this special movement of the thumb, opposition, and that's the ability of your thumb to reach around and touch every one of your other digits. It's what makes us tool users, and not very many animals can do it. So this is the special movement of the thumb. Wow, special for the thumb. And this is the movement where the thumb can reach around and touch particularly your 5th digit, but every digit. So the thumb can touch every digit. Okay. So apes who have opposable thumbs are also tool users because they'll stick their little stick into like a termite hole. And the termites crawl up it. And then they use the tool to eat their termite. Pretty cool. Gotta have opposable thumbs to use tools. Okay. So you've got all kinds of synovial joints, plane synovial joints, hidden synovial joints, pivot synovial joints. Look them over in your book. Ball and socket. I might say something you like. What joint is this? And what type of joint is it? You'd say, lady, there's not a bone in there. That's no joint. You fail. That is the acetabulum. You would be right. What joint is this? Well, we didn't actually have to know the specific name of that joint. You're right. Okay. So, well, what if I said, what type of joint is this? Synovial, ball and socket. You do have to know some specific joints. You have to know the sacroiliac joint. What type is it? Synovial. But it's not a ball and socket. That one's plain. So, just kind of read those over in your book. So yeah, just read over the basic types of each synovial joint in your book. I'm not gonna make you list out a comprehensive list. Give me every type of plain joint that you can think of in the body. No, but I might ask you, pivot joints allow you to move like this. Oh. So your joint between C1 and C2 is a pivot joint. I don't know, read them over. I think that is it for lecture material today. Let's see. Oh, almost. I have a question for you. The greatest degree of movement allowed by a synovial joint is uniaxial, biaxial, multiaxial, or all of the above. Greatest amount of movement is allowed in a multiaxial joint. Pointing your toes downward is described as which type of movement? Plantar flexion, hyperextension, hyperflexion, all of the above. Ah, plantar flexion, good job. The one other joint that you need to know in great detail is the knee joint. And I love the knee joint. The knee joint is the most complex synovial joint in the body, and that's because we have lots of bones coming together. What do we have going on here in the knee joint? We've got the femur articulating with the tibia, and then the patella attaching across the joint. So, what are the structures that you need to know? Well, first let's say what's cool about the knee joint is that when it locks in place, it takes all of the work off of your muscles. So it's unique among synovial joints in that regard. If you lock your knee, your muscles don't have to do anything else for you to stand up. Imagine if I locked my elbow and tried to stand on my head all day, or hands all day. I'd get tired real fast, right? Because the joint doesn't lock in the same way, and the arrangements of muscles isn't the same. So all day long, if I was standing on my hands, my muscles in my arm would have to work to hold that joint stable. Not so in the knee. So it's pretty cool. Yeah, so we'll say you can lock and remove all the pressure from the muscles. So my first job was a Dairy Queen, and I worked in the drive-thru, and I could lock that knee joint and stand for 8 hours straight without moving. Welcome to Dairy Queen, how can I help you? And it was because the knee joint's so cool. Okay. All right, so what are the things we need to know about the knee joint? femur and the tibia and the patella are the bones that are involved. This is the quadriceps femoris tendon that's going to blend with the patellar ligament and attach to the tibial tuberosity. Okay, so you have to know that. Patellar ligament, quadriceps femoris tendon, they merge together, everything's attaching on the tibial tuberosity. Okay, now you've probably heard, oh, I tore my ACL, my PCL, whatever. ACL, we've got cruciate ligaments and collateral ligaments. So we've got two types of each. Our cruciate ligaments are going to be the ones that limit movement in the anterior and posterior direction. Or we could think about that as in the sagittal plane. So our cruciate ligaments limit movement in the sagittal plane. And then the second type of ligaments that we have are the collateral ligaments, and they limit movement in the frontal plane. Collateral ligaments, and they limit movement in the frontal plane. Okay, so your ACL is your anterior cruciate ligament. Your PCL is your posterior cruciate ligament, and those are the only names those two get. So if I see in old models, they didn't like cleverly make it so that you could just like pull this off, and students were popping off patellar tendons all the time. It was bad. Patellar ligaments and quadriceps femoris tendons. It was bad. Okay, here is my anterior cruciate ligament. Here is my posterior cruciate ligament. Okay, they limit movement in the anterior and posterior direction, or in the sagittal plane. Here, these ligaments, our collateral ligaments, have two names. Our tibial collateral ligament, or TCL, which is also the MCL, the medial collateral ligament. And then we've got the fibular collateral ligament, which is also the lateral collateral ligament, the LCL or the FCL, okay? ACL, PCL, MCL, LCL, TCL, FCL, what the L? That was pretty good. Okay, so for our cruciate ligaments, we've got anterior and posterior, and then for collateral ligaments, we have the tibial collateral, which is also the medial collateral ligament, and we have the fibular collateral, which is also the lateral collateral ligament. And I think the only other things that you have to identify in the knee joint are the menisci, which are pads of what? Fibrocartilage, right? That reduce the compressive shock in this joint. So, medial meniscus, lateral meniscus, medial meniscus, lateral meniscus, lateral meniscus, medial meniscus, ba-dang dang, we're done with joints. All right, so I will see you soon in the Teachers Helping Students Succeed. All right, I will see you soon in the Teachers Helping Students Succeed discussion board. Let me know if you have any questions.